Good day, everyone. My name is Dr. Bertrand Odume. I'm the Executive Director of Knowledge Network for Disease Control and Vigilance, KNCV Nigeria, and today I'll be talking on accelerating TB eradication, lessons from Nigeria for Africa and the rest of the world. And this is my presentation outline. I'll use the opportunity to tell you more about KNCV Nigeria and our projects. Rationale for TB lamp introduction, what actually informed the strategic expansion, the scale-up of TB lamp in Nigeria, some achievements we were able to record, some key successes, and some challenges and areas we think there may be need for improvement. Conclusion, and we're able to acknowledge some of the key actors that made this introduction possible. First, KNCV Nigeria. The history of KNCV in Nigeria dates back as early as 2004 when KNCV Global established their presence supporting the national government and the national TB control effort with funding from United States Agency for International Development. They had a series of projects, 5-year grants supported by USAID, but not until 2016-2020 that we came on board as a national entity with support, a bridging grant from USAID under the SHORTS project. We're able to establish a national entity today known as Knowledge Network for Disease Control and Vigilance, KNCV Nigeria. And since 2020, we embarked on our very first flagship project, the TB Loan. We've undertaken increasing number of projects, diversifying our portfolio to areas of health system, HIV, AIDS, and other funding portfolios from Global Fund, the Impact Project, and the CPPM, and even currently supporting the national program in the ongoing drug sensitivity testing and a research grant currently with Gates Foundation. We call the Gates Test Project. Now, with ongoing projects, we pride ourselves that presently KNCV in Nigeria has footprints across all the states in Nigeria, and we know the population and the TB burden, and we have worked successfully with National TB Program to intensify and scale all proven intervention across the country. Now, for TB lamp, what's the rationale for TB lamp introduction? We introduced TB lamp at the start of the TB lamp project in 2020. We know the limitations of culture and direct microscopy. This has necessitated recommendation for molecular tests by WHO, introducing GeneXpert, TB lamp, and very recently, even TrueNat technology as the initial diagnostic test. Now, given the vast population of Nigeria, the increasing burden, the endemic nature of TB, and power challenges in rural areas in Nigeria, it was unrealistic to continue to drive XPAT as a primary diagnostic tool, considering some of these challenges. And the TB lamp was introduced by KNCV Nigeria in collaboration with National TB Program through USAID funding to close testing gap, which had remained a challenge in finding TB cases in Nigeria, and more so to complement GeneXpert in most power challenge locations. Now, this is actually our journey, starting from the conceptualization of the TB lamp introduction, the pilot phase, where we started with only 5 TB lamp tools in Nigeria to where we are today. And the pilot informed development of normative guidelines, SOPs, the scale-up phase, and policy reevaluation. That is defining the future for diagnostic technology introduction in Nigeria currently. Now, let's look at the conceptualization phase. The poor TB case notification and low utilization of GeneXpert machine were great concerns to KNCV and the National TB Program at the onset of TB Loan. TB Loan project, a 5-year grant where we were to provide support to ensure TB scale-up, and even meant to find over 300,000 TB cases in a 5-year project. And we needed to optimize our diagnostic capability. These were primarily due to infrastructure challenges, low throughput of the 4 modular GeneXpert machines being used. And we were actually very concerned looking at the number of cases expected in that 5 years that we needed to do things differently. We need a tool that can withstand our high temperature. Nigeria is a temperate environment, a tropical country, and a dusty environment. And most of these diagnostic sites are in very rural areas that have interrupted power supply. Some of them are not connected to national grid. And we needed a tool that will be able to test multiple samples in a run, considering the high volume of sample generated during community active case finding. It must be rugged enough to withstand frequent tear and frequent wear, and transportation will actually be in a portable condition across most rural communities for our active case finding. And we couldn't think of any other better diagnostic tool than TB lamp. Now, reasons for choosing TB lamp, as I've already said, it does not require an air conditioner to function optimally. Where we have supported other diagnostic tools like GeneXpert, you must optimize the lab by providing ACs, ensuring that testing are done within optimal temperature. Instruments for TB lamp are simple and user-friendly, the human loop and the centrifuge, as you could actually see in the picture. It uses solar system. This is very, very key in rural communities, in developing countries where there are pervasive power challenges. And the turnaround time is less than 2 hours, ability to test over 70 samples in a day, and actually best suited when you move for community active case finding, where increasing number of samples are generated, and the good sensitivity and specificity. And this actually we validated in country in our pilot study. I would like to talk on the pilot phase, because when we look at the successes of TB lamp today, moving from just 5 tools to over 300 in country. It started with this pilot that KNCV Nigeria, the introduction of the TB lamp project, did this pilot in 2 states, Kano and Anambra State, across 5 investigative sites. You could see the picture there, looking at the mask and social distancing. This happened in the peak of COVID, and this is one of the private labs where we conducted a pilot in Anambra State, southeastern Nigeria. What was key, the result was actually published, and if you look at the result, where we compare the sensitivity and specificity of GeneXpert with TB lamp and the AFB microscopy, and it was actually very clear and not different from other studies published before now. Looking at the sensitivity of 84.5% for expert, 76.79% for TB lamp, and 54.3%. This actually shows clearly that we can actually compare the sensitivity of TB lamp with expert, and far two of them outweighs that for AFE microscopy that had remained mainstay in rural active case finding in Nigeria. And this actually informed some of the introduction and the evidence behind the scale-up of TB lamp. And looking at specificity, everything actually almost shows the same figure, from 99.1% for GeneXpert, 99.3% for TB lamp, and 99.8% for what actually came out from the study, that we can confidently replace some of this AFE microscopy with TB lamp, considering some of the advantages I've actually stated before now. Now, installation and training phase, we've developed our capacity implementing the pilot. And KNCV Nigeria will commence the implementation with these 5 pilot instruments in the 2 states in 2021. After developing the protocol, getting it approved by NREC, additional instruments were procured with USAID funding at the start of this pilot, adding to the 5 instruments we have. We already received gift donations of TB reagents from partners like Odume, is a private sector operator in Nigeria with interest in TB program, Human Diagnostic Tool, and BOA Group that actually supported by providing reagents. And what was actually key in our success, that Human were very early in this introduction to identify a local partner, MacPage, for diagnostic tool maintenance and even facilitation and support to entire stakeholders. A strong monitoring and evaluation system was actually put in place at KNCV. We have dedicated focal points, and we have visibility across all the lamp tools in the country, looking at optimal functionality, the availability of reagents, and receiving our reports every week, and we present those reports to the funders, especially USAID. The National TB Lamp Implementation Guideline and SOP, where the development of these normative guidelines were actually very key in the scale-up efforts. And the assay was also integrated into the national diagnostic algorithm. Before then, the primary diagnostic tool had remained GeneXpert, but with the proven successes in our pilot and the buy-in by the national program, they were able to adopt the TB lamp technology. And in that pilot, we were able to develop YouTube videos and a whole lot of sensitization in country. These are actually the National TB Lamp Implementation Guideline, which was actually facilitated with our collaboration with the human in-country provider, MacPage, and working with the national program. This actually set the tune, helped to build capacity of staff for the continued rollout of TB lamp in country. Now, this might appear very busy, but what is very key here, we looked at the guideline. Before the introduction of TB lamp, you could see here what were there that primary diagnostic tool had remained gene expert. But following the successes of our pilots, the buy-in by the national program, TB lamp was actually introduced as one of the diagnostic options. But the very, very key thing there that testing with TB lamp, you expect if it's negative or it's positive. Only the positive samples will pass through any of the other molecular diagnostic tests for resistant testing. And this had actually helped improve diagnostic utilization and optimization and efficiency in diagnostic testing across the country. Now, the scale-up phase, coming from the pilot and buy-in from the national program, what next we needed to scale, because I must tell you that the only impact one will be demonstrated in Nigeria with our number of population, increasing the number of states and the burden of TB is when some of these innovations are taken to scale. The comprehensive database from the pilots and the weekly performance data tracking from our MI unit made adoption and scale-up of TB lamp seamless. The evidence was there. It was easy to convince funders to procure more machines with proof of concept from pilot study and the scientific evidence from the performance review. The pilot was presented at Union Conference and we were very fast in publishing our data in Greener Journal, where actually increasing number of the audience had to see our own in-country experience. And in 2024, 100 TB lamp machines were procured and installed across all the states with Global Fund support. Laboratory staff were trained and retrained on TB lamp per se, and massive sensitization of healthcare workers. Actually, what actually came out here is that it was a new tool. When we trained the laboratorian, we probably sensitized the healthcare workers to see the need for referral to across all the diagnostic setup. Now, coming from our implementation, this is actually very unique to our project in Nigeria. We're able to come with 3 models for deployment of TB lamp. We call the model 1, 2, and 3. In the model 1, you use of TB lamp installation in power challenge hard to reach communities lacking molecular diagnostic tools. In most instances, some of these facilities used to have a ASV microscopy, but the capacity had come down and it was very easy to replace some of these ASV microscopy with TB lamp. In some of these facilities, there are pervasive power challenges, but TB lamp comes with its own solar panel and it could actually function optimally in some of these facilities that are not connected to national grid. In the model 2 is used in high burden facility to complement Gene Expert or TrueNAT. We're able to publish some of these studies and the implementation sciences around this deployment in the Union Conference. And when we first did was in Kano, one of the highest burden facilities, where we keep on having diagnostic gap and wastages of sample. By installing a TB lamp, just one singular tool in that facility, we could see a sharp decrease in diagnostic gap and increased utilization at that facility. And this is actually a tested model. And the third model, which is unique, that where we couple the TB lamp with awareness on Keke, I'm going to show some of the pictures, is very suited for community deployment. And this awareness on Keke will take on TB lamp and a digital X-ray, and they are mounted in community and ensures on-the-spot diagnostic testing. This actually is the picture. This is awareness on Keke, which we actually introduced. It was a child of necessity. We introduced this during the COVID, and after COVID, we were able to for optimize the utilization. You could see digital X-ray here and TB lamp technology. It goes with the team moving from community to community. In the picture there, you could see awareness on Keke mounted in a very rural location. You could see people. It comes with a wow mode that attract even community members. And the one good thing is a one-stop shop. People line have the X-ray review, presumptive are profiled, and right there on the support, they are provide their sputum, and the TB lamp is used to molecular diagnosis. And those that are found to have TB are immediately linked, because in most of these community interventions, we move with the state TB team, the local government supervisors, and before then, we map out facilities, diagnostic facilities, and treatment sites where diagnosed TB cases can actually be linked for treatment. Now, we'll talk on the results, the impact of the scale-up. And one thing that is very key here, you could see increasing testing, increasing cases being found as we move from 2021, as we increase the number of machines from 11, we're looking in 2021 about 30,000 tests done, to 22, we're looking at about 39,000 tests, to 16 machines in 2023, to over 120,000 tests. And until we reach a peak, about 83 machines in 2024, 343,000 cases were tested. An increasing number of tests with a demonstrated yield, which averages about 5, 6, and even 8% in some states. You could see the increasing number of TB cases being detected through the expert technology. You could see in 2025, it may seem as if they are a dip, but this actually result for only 2 quarters. And by end of 2025, this actual result as at August, we've scaled the TB lamp technology from 11 machines in 2021 to 100 machines by the end of August in 2025. But even as I'm talking now, increasing numbers are being deployed across the country. Now, the policy reevaluation, which our introduction, the pilot phase, the experience we've generated in country had informed that prior to 2020, TB lamp, expert, and TrueNAT were all used as initial tests where available, and positive TB lamp samples were processed with GeneXpert or TrueNAT for resistant testing. As the country got better with implementation strategies, the number of samples for laboratory tests steadily increased. If I tell you the story of case finding in Nigeria, where we have remained very stagnant to moving and closing the TB case finding gap from over 70 in the last 5 years to even within 15%, and optimizing diagnostic technology had actually remained one of the key success stories. As the country got better with implementation strategies, as I said, the number of samples needing tests increased, and the need for scale-up of molecular diagnosis. Lab with low throughput instruments were increasingly overwhelmed with high workload and widening evaluation gap. And this informed a change in policy. I must commend the national program, because looking at all this and their drive to ensure TB eradication in Nigeria, there's a new policy reevaluation that the recommendation now is use of TB lamp and not even the GeneXpert or other molecular tests for initial testing. And a whole lot of evidence informed this, all which I've showcased here, and most importantly, efficiency in testing, where tests with GP lamp compared to some molecular tests, you could actually say the cost savings in dollars. Positive samples still processed with GeneXpert or TrueNAT for confirmation or reef testing, and that's what actually is in the guideline. The approach facilitates high volume testing and the gradual closing of evaluation gap, which I will show in the next slide. Look at the relationship between increasing number of expert deployment, the number of testing being done, and the closure in evaluation gap. At our start of introduction of TB lamp in 2021, you could see that the evaluation gap for testing is almost about 34%. But as we continue to work with the national program or other partners to increase the TB lamp deployment, we gradually started deploying TB lamp across most facilities through those 3 models, and you could see gradual decrease in evaluation gap starting from 34 in 2021 to 2023 in 2022, 18% in 2023, 10% in 2024. And by the time of the report for just the 2 quarters in 2025, we've been able to close diagnostic evaluation gap in Nigeria by almost down to 0. And you could see the increasing number of TB cases being screened with TB lamp, and increasing number of yield, as you could see in the table at the end or upper part of this slide. Now, what are the key results for the time starting from 11th February 2021, we started with 5 TB lamp, 11 TB lamp to the end of August 2025. Within the state we support at KNCV Nigeria, the 14 states as shown in map, we're able to test 856,153 samples, of which we detected 67,015 TB cases. And reef susceptible strains tested, and the detected cases of reef by algorithm resistance state was 2,647. Now, the key success stories, I think this is a very key takeaway from this presentation, that we did not do this alone. We first had our conceptualization, developed the proof of concept, had stakeholders engagement. This is actually very key in success, because introducing a new tool, you need the buy-in, you need them to be convinced that they need to do things differently. And there was actually need for strategic placement, because by the time we're introducing TB lamp, other diagnostic tools were available in facilities. So you need to do your mapping, know where there are greatest gap and where you have the greatest need. And I must sincerely say that robust data must be in place, because we're able to work with the national program, leveraging on the evidence we have, looking at with data. I know when they were discussing Global Fund, they will always call on us to share data, share information, and having those evidence and very robust database could inform buy-in by funders. And well-articulated transition plan, I think these are even very key. It should be strategic expansion, that informed by evidence, support for normative guidance, introduction, training, and human resource capacity, and setting up a very robust monitoring system. Having visibility of this expert to ensure that maintenance is optimal, supply of reagents is there as and when due, and we will be able to report on the numbers. But in all, having the stakeholders buy-in, the government buy-in for sustainability. We're able to introduce USAID supported Global Fund, but the national program had taken ownership significantly over time. And it has become routine that in most facilities, I've seen most state government buying TB lamp, procuring reagents. And considering the cost is very affordable, the instrumentation very minimal, and even to train staff to operate this at the lowest level of facility had made this seamless scale-up very possible. Now, some challenges and areas of improvement. I think this comes with a very strong recommendation coming from my experience over years. I must say it's about 6 years we've been with the technology in Nigeria. Sample other than sputum cannot be processed using TB lamp. I think this is a challenge for the scientists to do more, but I'm sure there are already some literatures in there, some use of TB lamp in samples other than sputum. No digital connectivity interface for real-time data upload. We're able to develop our own in-house visibility, having to identify focal points at site, making calls, setting up WhatsApp groups. But I think if this system is automated, the national program will be able to have a dashboard where they will have visibility of the tools across the country, and we're able to shorten the response time when there's need to provide any support, be it equipment breakdown, be it need for supply of reagents. I think that real-time data visibility will be very key in addressing this. Test results are not stored on the platform for future reference and process validation. I think when this is looked into, it will actually help to give more transparency and visibility to ensure timely response for any key challenges across all the increasing number of platforms in the country. In conclusion, TB lamp is an alternative test for sputum smear microscopy. We've documented it globally. We have the results in Nigeria, and all these are there for anyone to look into. It is is valuable in settings where resources and infrastructure requirements for other molecular tests, such as expert technology, are inadequate. In developing countries that actually bear the highest burden of TB, I don't think there's any other better option for us to improve in our diagnostic scale-up than what we've been able to do with TB lamp. It's suitable for community ACF owing to its portable nature and use of solar system, and has improved diagnostic services to underserved community. We've demonstrated this, and this actually informed our third model, where we've optimized the use of TB lamp in a mobile fashion, moving from community to community. TB diagnostic tool has significantly breached the diagnostic gap and ultimately increased TB case notification in Nigeria. We demonstrated it under our project. moving from over 35% gap in TB diagnostic gap to almost zero by the end of second quarter this year. I think we give that to our thinking, and I would say thinking outside the box, because we felt that there was need for us to do things differently when it comes to diagnostic optimization in Nigeria, and informed our introduction of the TB lamp technology. I must not end this presentation without acknowledging some of the key players. I'll start with National TB Program. KNCV is like the national. We've worked very closely with them, and they gave us a platform. We wouldn't have been able to demonstrate the successes we demonstrated not only with TB lamp but other diagnostic tools without acknowledging the National TB Program, Federal Ministry of Health, and the 14 states where implemented the TB law, including the facility staff. The United States Agency for International Development, defunct now, actually gave birth to KNCV in Nigeria through some of these innovative projects. The Global Fund, KNCV Nigerian staff members, and I must equally thank Human Diagnostics, who've actually worked well. They have made donations to the country, they have provided all the support that we need, and we can talk about the success stories, the lives saved in Nigeria, deploying TB lamp without mentioning and thanking them. And the last but not the least is mark page investment. This is actually one of the key strategies in Nigeria, that they were able to bring on board a local service provider early that understand the terrain, that have been able to work with not only KNCV and other partners in National TB Program. And all the team working together actually must be acknowledged for the successes we've recorded in Nigeria. Thank you from all of us at KNCV Nigeria.